Bismillahirrahmanirrahim. Assalamu alaikum everyone. This is Dr. Mubasshra, and in this video we will discuss about dengue fever. What is dengue fever? Warning signs of dengue fever, admission criteria, that is when to admit the patient, fluid therapy, which IV fluids should be given, role of platelets, and discharge criteria of dengue fever. So let's start. Dengue fever is divided into three categories: suspected dengue fever, probable dengue fever, and confirmed dengue fever. Probable dengue fever is defined as fever along with two of the following features: nausea, vomiting, skin rash, arthralgias, myalgias, and positive tourniquet test. Confirmed dengue fever is defined as clinical features of dengue fever along with positive lab findings. Now let's discuss about the warning signs of dengue fever. They are divided into clinical criteria and laboratory criteria. Clinical criteria includes abdominal pain, tenderness, mucosal bleeding in the form of hematuria, GI bleed, epistaxis or heavy menstrual bleeding, and fluid accumulation in the form of ascites and pleural effusion. Lethargy, persistent vomiting, and hepatomegaly of more than 2 cm are also included in clinical criteria. And the laboratory criteria includes increase in hematocrit with rapid decline in platelets. Now the question is, which patients need admission? For this, we divide the patient in three groups: Group A, Group B, and Group C. Group A patients include those patients who have no warning signs and who are able to tolerate adequate volume of oral fluids and pass urine at least once every 6 hours. These patients do not require admission. OPD management is sufficient and patients should have a regular follow-up. Group B patients include those with coexisting pregnancy, old age, obesity, diabetes, renal failure, chronic hemolytic disease, or have warning signs. And Group C patients have severe dengue fever, patient is hemodynamically unstable, or has bleeding or multi-organ dysfunction. Such patients should be admitted. Now let's discuss about the treatment of Group A patients. This includes bed rest, plenty of fluids in the form of ORS, coconut water, but avoid excessive plain water in order to avoid hyponatremia, and paracetamol for high-grade fever. Tepid sponging if the patient has high fever. Tap water, not ice cold water, is recommended to avoid vasoconstriction of blood vessels of the skin. Do not take aspirin, ibuprofen, diclofenac, and ask the patient to report to hospital immediately if there is any risk of bleeding, nausea, vomiting, severe abdominal pain, breathing difficulty, and patient is not passing urine for more than 6 hours. Now let's discuss about the treatment of Group B patients. First of all, we will look for warning signs. If the warning signs are absent, then we will give the patient fluids in the form of IV fluids or oral fluids. But if the warning signs are present, then we will advise baseline hematocrit. After baseline hematocrit, the treatment of choice is isotonic fluids at the rate of 7 ml per kg per hour for 2 hours and then 5 ml per kg per hour for the next 4 hours, and after that 3 ml per kg per hour for next 4 hours. After that, check hematocrit again. If it stays the same, then fluids are given at the rate of 3 ml per kg per hour for the next 4 hours. And if there is increase in hematocrit, then the fluids are increased at the rate of 5 to 10 ml per kg per hour for the next 2 hours. Now, the question is how to choose IV fluids. The choice is either crystalloids or colloids. The crystalloids are in the form of 0.9% normal saline or ringer lactate. Ringer lactate is preferred if the patient has hypernatremia or hyperchloremia, but it is avoided in liver failure or if the patient is on metformin. And the colloids include dextran based, gelatin based, or starch based colloids. Now let's discuss about the maintenance fluids. They are given at the rate of 4 ml per kg per hour for first 10 kg body weight, then add 2 ml per kg per hour for the next 10 kg and plus 1 ml per kg per hour for subsequent body weight. Let me explain it how it is calculated. For example, if a patient has 50 kg body weight, so for first 10 kg it is 40 ml per hour and for the next 10 kg it is 20 ml per hour. So total is 60 ml per hour for 20 kg. Now we are left with 30 kg body weight. So that will be 30 ml per hour. So the total fluid will be 90 ml per hour maintenance fluid. Now, what is the target of IV fluids? Capillary filling time less than 2 seconds and urine output of 0.5 ml per kg per hour. Caution is this that we should reduce IV fluids at the end of the critical phase. This is very important because at the end of the critical phase, fluid comes back into the intravascular space and there are chances of pulmonary edema and fluid overload. Now the question is, how will you assess that the patient is at the end of the critical phase? Here patient will have a urine output of more than 0.5 ml per kg per hour and has adequate oral intake. Now let's discuss about the treatment of group C patients. It is again divided into two categories. One is the treatment of compensated shock and another is the treatment of hypotensive shock. So first of all, we will discuss about the treatment of compensated shock. So first of all, we start with crystalloids at the rate of 10 ml per kg per hour over 1 hour. If there is improvement, then we will give the crystalloids at the rate of 7 ml per kg per hour for next 2 hours and then decrease it at 5 ml per kg per hour for 4 hours and then 3 ml per kg per hour for the next 4 hours. However, if there is no improvement with initial crystalloids, then we will check hematocrit. If it is showing increasing trend, then we shift to colloids at 10 ml, 10 to 20 ml per kg per hour for 1 hour. If there is improvement, then again the same strategy as with the crystalloids. But if there is no improvement, then again we will check the hematocrit. If it has increasing trend, it means there is bleeding. So blood transfusion will be given. Packed RBCs in the dose of 5 to 10 ml per kg body weight is given or whole blood at the rate of 10 to 20 ml per kg body weight. Mega units can also be transfused and platelet concentrate as well. Now let's discuss about the role of platelet transfusion in case of dengue fever. There is no exact role, but we give it prophylactically if the platelet count is less than 10,000. Now let's discuss about the treatment of hypotensive shock. Again, the treatment of choice is crystalloids or colloids 20 ml per kg over 15 minutes. If there is improvement, then we give crystalloids or colloids at the rate of 10 ml per kg per hour for 1 hour, then decrease it to 7 ml per kg per hour for 2 hours, then 5 ml per kg per hour for 4 hours, and then 3 ml per kg per hour for the next 4 hours. However, if there is no improvement, then we will check hematocrit. If it is increasing, then colloids are given at 10 to 20 ml per kg over 1 hour. There is no role of steroids, papaya leaves, aloe vera, and goat milk in dengue fever. Now let's discuss about the discharge criteria in case of dengue fever. Again, it is divided into two criteria, clinical criteria and laboratory criteria. Clinical criteria includes those patients who are afebrile for the next 48 hours. Patient is generally well. There is return of appetite. Patient is hemodynamically stable. He has adequate urine output and there is no respiratory distress. And the laboratory criteria includes increasing trend of platelet count with stable hematocrit without IV fluids. Thank you so much for joining. Stay blessed. Allah Hafiz.